It's very true that to get a good seat at the back, you have to arrive early. So if anybody would like to move a little bit closer, that might be helpful. I'll just give you a minute to come forward. Thank you. So, good evening. My name is Anne Mahon. I am a Professor of Health Leadership at Alliance Manchester Business School and Head of the Health Management Group. And I'm absolutely delighted to welcome you here this evening to the annual lecture that we hold in honour of Teddy Chester and the legacy, in honour of Teddy Chester and the legacy that we have inherited from Teddy Chester. This annual lecture was started in 2005 by Professor Kieran Walsh in recognition of Teddy Chester's accomplishments, influence and impact. It's an important date in the school diary, in our school calendar and an event we look forward to very much. Our lecture this evening will be delivered by Anita Charlesworth. And Anita keeps good company. Previous speakers have included Rudolph Klein, Stephen Dorrell, Trish Greenhall, Jennifer Dixon, Simon Stevens, amongst others. Teddy Chester was the first Professor of Social Administration at the University of Manchester. From his appointment in the early 1950s through to his retirement in the 1970s, in 1975, he was an influential pioneer in management development using evidence and research with policymakers and working with clinical leaders. He was involved in founding what we now know as the NHS Graduate Management Training Scheme and in founding one of the founding professors of the business school in 1965. Teddy Chester's practice as an academic in Manchester is associated with a number of values and concerns that remain more than relevant today. He was concerned with research-led teaching, working with real-life management problems, supporting the NHS workforce to work collaboratively and across boundaries, and recognised the importance of using rigorous evidence in policy and management decision-making and management practice. More than 1 million people work in the NHS in England. Planning for the workforce is definitely a real-life policy and management problem that has major implications for the NHS now and in the future. The recently published NHS Interim People Plan committed to develop a workforce to deliver 21st century care, but the plan said little about how that might be done. I'm sure we'll gain some insights into that this evening. And so I would now like to introduce Anita Charlesworth. Anita is the Director of Research and Economics at the Health Foundation and Honorary Professor in the College of Social Sciences at the Health Services Management Centre at the University of Birmingham. Before joining the Health Foundation, Anita was Chief Economist at the Nuffield Trust, where she led the Trust's work on healthcare financing and market mechanisms. Prior to that, Anita has had roles as Chief Analyst and Chief Scientific Advisor at DCMS, Director of Public Spending at the Treasury, where she led the team working with Sir Derek Wanless. And also she's worked as an economic advisor at the Department of Health and for SmithKline Beecham Pharmaceuticals. Anita's lecture tonight is why are workforce issues so critical now and what would a good strategy look like? Anita.
Thank you so much for inviting me. My background is as an economist, and then also at the Treasury, so I don't really exist without charts. So there's quite a lot of charts here, but the purpose of the charts really is to tell a story. And inevitably in this, what I'm going to do is curate some data to try to tell you a story about where I see workforce issues at the moment. It's a partial story. When I was thinking about today, I obviously looked at a lot of the economics literature in this regard, but also looked at some of the sociological literature as well. And there are a number of really important insights from a range of different disciplines that are incredibly important to understanding the workforce. And one of the strengths of somewhere like Manchester with the multidisciplinary work that you do is bringing those together. I'm not going to do any sort of justice to that. I decided in the end that in 40 minutes it was just impossible and I'd stick to what I know and give you a perspective from an economist. I started out as a health economist, but I've spent a lot of time in government. So I'm going to try to think about the workforce really through three different lenses, which I think is quite important because often when I've looked back over what's happened over the last 70 years with the workforce, what you tend to see is to the extent to which policy does focus on the workforce, and one of the things I'd argue very strongly is it doesn't focus on it anywhere near enough. It tends to focus on the workforce in moments of crisis, and those crises are born out of two issues. Either, I can't get my pointer to work. Anyway, either an issue with the workforce capacity and access to care, and the history of the NHS is of repeated workforce crises with not enough staff, or as we saw with mid-staffs, and there are several people in the room obviously who've done an awful lot of work on mid-staffs around concerns about quality of care. Undoubtedly, thinking about how we make sure that we have enough capacity in our system to ensure that people have access to care, and that's not just overall numbers, but also the geographical distribution, the specialty distribution, different types of services, primary care versus acute care, is a central issue, and I've put it in the centre here. The other issue, clearly, which is the central issue, you're right, is quality of care. Those are really important, but I don't think they describe actually the totality of what workforce policy needs to think about. So around that, I think I would argue as someone whose focus is on the long-term sustainability of health and care systems, both the fiscal sustainability in particular. Healthcare productivity is hugely critical to long-term sustainability of the healthcare system. And workforce productivity, in the end, is the engine that drives overall productivity in all industries, and we are not alone. So we also need to think very importantly about productivity. And then the outer ring is something which I think is rising up the policy agenda, often talked about in relation to the anchor institutions agenda, is the recognition that with the size of the health and care sector now, what we do and the policies we have for the health and social care workforce are important for how effectively and efficiently our health and care system operate, but actually they drive wider labour market dynamics, they drive wider economic and social change. And then also if our policy is not cognizant of what's going on in that wider labour market, we will not be able to recruit and retain. So I would argue that one of the fault lines that we've had with workforce policy is it's normally too narrow. And it is born of crisis and focused either on numbers or, and actually often quality of care is basically numbers, that overwhelmingly it's focused on numbers and it has not thought enough about these other issues. So what do I, oh, that hasn't worked, has it? Oh. Now, I don't know what... Is it just that one? That on this? Yeah, everything else works. Sorry. Don't know what's happened in... I must be on a different version. Anyway, I'll skip it. Now, numbers do matter. If that chart were working, what it would show you is that there are actually a remarkably different pattern across the OECD. It looks at the number of doctors per 1,000 population and the number of nurses per 1,000 population, and there are countries with a lot of doctors per head of population and a lot of nurses. We're not in there. There are countries with quite a lot of nurses and less doctors. We're not in there. There are countries that have a lot of doctors and less nurses. We're not in there. We're in the small and select and ignominious band of countries that have very few nurses or doctors per head of population. And we're joined in that grouping by Korea, Poland, Mexico, Hungary, Israel, and Latvia. So basically, all of the countries really that have well-established healthcare systems that deliver universal healthcare coverage don't go for the staffing rates that we go for. And that has been a long-term issue in our system, probably significantly driven by my former colleagues at the Treasury's desire for control, which I think comes from a focus actually on short-term costs at the expense of thinking about that ring of productivity. So I think they are trying to deal with two issues in that. One is where the state has paid for so much of the cost of training, they're trying to reduce the cost of training. The other thing I think which has driven this is a US literature on supplier-induced demand, which has believed that if you train more doctors and nurses, you will end up then having to deliver more healthcare, and this would be a long-term driver of more expensive health service. Not recognising, I think, that the context between the US and the UK is profoundly different, and training more doctors and nurses has a cost. There are choices about who bears that cost and where the risk lies, but not training enough has a long-term hidden cost in foregone productivity. So that is our history and not new. The reason why I think we need to think about this a lot now is what the outlook looks like. And so this is some work that we did with colleagues at the King's Fund and the Nuffield Trust, where we at the Health Foundation did a report last year with the Institute for Fiscal Studies looking at the long-term demand pressures on the health service for the next decade or so. And assuming current staffing models, we convert that into a projected demand for healthcare workers, for NHS workers. And that line is the black line, dotted line there. Yeah. So you see increasing growth in healthcare workers. It starts from a position, though, you'll notice that black line, which is the demand, which is above the green line now. So the demand for healthcare workers is the black line. The green line is the supply of NHS staff. So at the moment we have vacancies of around 100,000, slightly more than that. Over 40,000 of those are nurses. The dark green dotted line, if supply continues on its current trend, that's what would happen to the supply of NHS staff. And that would leave us in a decade's time with a gap of 250,000 staff. Now, many of the factors that drive supply are moving in the wrong direction at the moment. So things like leaver rates have been increasing. Yeah. And if that trend actually continued, then actually you can get a shortage in a decade's time of 350,000 staff very easily. We're just about coping with 100,000 staff shortages. It's extremely difficult to see how you can continue to run an effective and efficient healthcare system if you had vacancies of 350 or even 250,000 staff. So we called our report on this Make or Break. In fact, I spent a lot of years starting from oneness, thinking about how to get the NHS enough money. I actually now think money is relatively easy. I mean, you just have to decide to do it. But once you've decided to do it, it comes on tap really straightforwardly, yeah? So, you know, a government decides, it's in a spending review, Parliament votes it, the money's in the purchasers and then the providers' bank accounts pretty much instantaneously. With the workforce, it's much more difficult, yeah? So if you haven't planned for this and put that in train, and you actually, and my numbers are anywhere near correct in terms of demand, and in 5 years' time, someone, or actually it might be sooner than that, it's possibly got a general election, haven't we? Someone says, actually, we would actually like to employ more NHS staff. It's quite difficult to turn that on instantly. So I think this is much more difficult and fundamental than money. So the numbers issue, which has been the trigger for focusing on workforce, is a real issue, again, in the NHS. But there is also, obviously, some evidence that would suggest that we should care about this for quality reasons. And Linda Aitkins in the US Department of International Collaboration has done a lot of interesting work on the relationship between staffing and outcomes. I mean, in all of this, I'm going to give you a selective flavour of the issue, not a systematic review of the evidence. Yeah? But a paper she did with colleagues in the Lancet in 2014, again suggesting that nurse staffing, in terms of the number of patients each nurse is looking after, is related to outcomes in terms of mortality. And then the other thing is some other work that was done with Anne-Marie Rafferty and Jane Ball, amongst others, in BMJ Open last year, looking at the relationship between patient satisfaction and staffing, which found, I guess, that patients noticed in a large number of cases that there weren't enough staff, and that where they felt there weren't enough staff, they were much less likely to rate their care as excellent. So those two things that are in the centre here do see, you know, we have got another crisis point potentially with capacity, and it does matter for quality, I think, as well. But the other thing that I think makes this really difficult going forward is thinking about NHS and social care staffing in the context of what's happening to our labour market as a whole, now that health and care are such a large part of economic activity and the labour market. So what I did, which was quite fun, was have a look at what the ONS expects to happen to the working age population. It's people between 16 and, I think, would I do 67, something like that, over the next 15 years, yeah, and in England. And so the working age population in England is due to increase from about 35 million to 37 million, yeah. So that's 2.3 million more people, a 6.5% increase. And then I converted my numbers on full-time equivalents into sort of head count. So there's quite a lot of jumps here, you know. This is illustrative, broadly right, precisely wrong, yeah? But nevertheless, it's kind of, I think it's quite a gulp moment, especially when you see the second one. And my numbers would suggest that without a radical change, either because of technology, skill mix, or my demand projections are really wrong, and we magically reduce demand in ways we haven't done before, that we need about 700,000 more people to come and work in healthcare over that by that 15-year period, a 60% increase. So you need 700,000 out of potential pool of 2.3 million people who are of the right age to come and work. And then you add social care in, which is quite important as well. And there's another 600,000 here, because our LSE, again, if you do the same things with LSE's projections, you get 40% increase in the social care workforce. So we've got potentially 2.3 million more people who might be employed in the country, assuming they all want to work and all of that, and are all capable of it. And in the health and care system, we need 1.3 million of them. So those of you here who are involved in the training of healthcare, smart move. Good job to be in, I think. But, as an economist, I think, this is quite a challenge, So actually this next period, even if my numbers are out by really quite a big margin, they'd have to be out by the most enormous margin for you not to think, Houston, we may well have a problem. So this makes you think, gosh, we should not be taking this stuff for granted. And then you think, well, how attractive have we made working in our sector? Because as an economist, you think, well, if we're going to take a higher proportion of those of working age in the labour market, we need to be quite attractive in the various different ways. So I think about pay, because I am an economist, but there are other things as well. And if you take our hospital nurses, broadly, the OECD data would suggest that hospital nurses in the UK earn about the average wage. So it's not awful, but this is a degree level occupation. That doesn't necessarily mean that you think that it's going to be hugely easy, as is. And then I look at what's happened to wages of people in the system compared to the other things that they could do. So this is from the beginning of austerity in 2010 through to August 2019, which is average weekly earnings data. And what you can see, and so the health and social work, which is what's available in terms of the cut for this, is the red line. Blue is the whole economy. Purple, what's happened to the private sector. You remember we nationalised banks, so the yellow is the public sector, excluding the fact that very rich bankers came onto the public sector payroll. Maybe that's the solution. Anyway, and what you can see is from 2010 through to 2015, there was some sense in which we are all in it together, had some basis in reality. So it wasn't a great time for earnings, but everyone's earnings were falling in a similar way. From 2015 onwards, other parts of the economy, particularly the private sector, have picked up a bit. Only still not back to the peak of earnings, which is one of the reasons why we're in the many messes that we're in at the moment. But even with a Gender for Change pay deal starting to come on, actually the relative wages in health and social work have fallen over that period. So we've got to persuade more people not to join those other bits of the economy, but to join our bit when actually we're becoming financially relatively less attractive. And then when you think about that wider piece that was talking about the role of the NHS in the labour market as a whole, I think it's really important then to think about both gender and ethnic makeup of the workforce. And overall, we have a highly feminised workforce, as we know, an increasingly feminised workforce in some areas, like medicine. Very variable, though, but highly feminised overall. And in key areas, we do also have a lot of staff from black and minority ethnic groups, and are an important employer for people from black and minority ethnic groups. So will have quite an important effect overall on the extent to which things like wages between different groups, men and women, BAME, citizens and white citizens are equal. And again, our position on this is not universally great. So we have, at the end here, obviously a gender pay gap. The pay for different ethnic minority groups is more complex. But what we see clearly is that for Black African, Caribbean and Black British staff, for men and women, average pay is below that for their white peers. Again, not making us self-evidently the most attractive place to come and work. Yeah. Ooh. Something strange is happening to a couple of my slides. Now, what's quite interesting is there are 2 slides there showing up. Don't know. The other thing I think that's really important there is I had a look at what's happened to women's employment over the last 20-odd years. Perfect. And the red is women employed in what the ONS classify from the Labour Force Survey as human health and social work, which has increased. But this is against a picture overall in the blue of women in employment. So the options, the number of women in work is increasing significantly through this period. But what's quite interesting is the number of options for women are increasing importantly as well. So I just think this, the mindset that often has dominated in healthcare, that has thought about our labour market as a closed labour market, that really doesn't have to think about what's happening in other parts of the labour market, and doesn't actually have to think about its responsibility overall to the dynamics in the labour market, is well past its sell-by date, if it was ever appropriate at all, which I doubt it was. And we have a sense, I think, that these are good jobs, and so it's just down to us to put the money in and expand the number of jobs, and people will come, and we don't have to worry actually about how attractive these jobs are fundamentally. It's just a planning exercise. It's not. I think we really do have to think about how attractive we are, both to join health and care and to stay in health and care. And this, I think, is really important when you start to think about the international context, because one of the reasons why we've got away with not thinking about this very much for quite a long time is because we've been able to recruit from abroad and essentially used international recruitment as the get-out-of-jail-free card for failed policies domestically. And the global position, according to the WHO in its Global Strategy for Human Health Resources, is working against us. So in Europe, this is region, so this is the 52 or whatever it is countries of Europe rather than the EU. So I'm allowed to talk about Europe in this context. It's still European in this context. And the position here, if you take demand and supply, is that across Europe region, WHO estimate that there's 1.5 million shortage this year, in 2013, of healthcare workers. And that's going to be pretty stable out to 2030, yeah? So across Europe region, things don't get worse, but they don't get better either. But that's a context globally, which is my grand total, where actually the shortage globally in 2013, they estimate at just under 5 million, but that rises by 2030 to 13 million. As countries commit to sustainable development goals and put in place, universal healthcare coverage, as the particularly middle-income countries develop chronic diseases rapidly, ageing populations as well, and just a huge growth in population, then we are struggling to keep up. So the strategy that says, oh, we don't have to worry too much, we speak English, the UK is attractive, we'll just get more people to come in from abroad, looks quite challenging over the longer term. And on the productivity piece, I think this really matters, because the typical way that what happens, basic economics, if you've got a shortage and you want to attract more people in, is you pay them more. And if you haven't trained enough, what we've done over recent years is paid them more via the agency route and spent a lot of healthcare money on agency route. Prior to 2010, pay costs, which is the dotted line, as you see, were rising significantly higher than the solid black line, which is general economy inflation, and were one of the biggest drivers of healthcare costs over the medium term. We had, for a few years, a very unusual period where actually pay costs, the dotted line there, which were below, as we held down NHS wages, for a period, where pay costs were really low. And so actually the healthcare money that went in was less, the growth in that was less than in the past, but it went a lot further, because essentially staff agreed to take the hit and see their real earnings fall. But we can't rely on that, and we're more likely to return to high pay growth unless we do something about that. And this really matters for productivity health service, and that in turn really matters for fiscal sustainability. So overall, over the last 20 odd years, the ONS estimate that productivity across the health service has increased by just under 1% a year. And as you can see, it did tick up over recent years. We've done quite well, largely because whilst activity and output, the red line, continued to grow, actually input growth really has moderated. So we've held down pay, but then what we've also done is employed fewer people, carried vacancies, and got them to do more, and hoped that quality wasn't impacted too much. Now, actually, the OBR, should say OBR, not ONS, OBR, see, it does even more broad brush numbers than me, It produces, I think it's every other year now, a fiscal sustainability report, which looks out over 50 years at what's going to happen to tax and spending and other fiscal risks. And what it does is model two scenarios for healthcare spending. So one, which is the blue line, and this is share of GDP on the side. On the blue line, it has, if healthcare productivity grows at the trend rate of growth for productivity of the economy as a whole, which used to be 2.2%, and then it has the red line of what would happen to healthcare spending if it grew, and they use 1.2%, which is not that different to the last sort of 20-odd years experience. And as you can see, in terms of share of GDP, well, we never quite get to the US levels. So in one sense, this is all achievable because, it is achievable, it's just a choice. Because the US already spends a bigger share of GDP than the OBR says we might. But what you see is we're spending the difference in the share of GDP that we end up devoting to healthcare for the same access and quality, is enormous, depending on what happens to productivity. And the sky won't fall in, if we're on the red line, It's doable. But it means that we can't do other things, either invest in other public services, which may benefit health, and arguably may benefit health more than healthcare benefits health, or actually, tax people less so that they can do other things with that. It has a consequence. So I think the OBR have healthcare spending as the highest impact, highest probability fiscal risk for the UK. And fundamentally, what drives that is labour productivity, so the extent to which is not how hard people work, but how well we support people in the skills we give them and the way we use those skills, and the other things like the capital investment we provide to enable them to deliver care efficiently and effectively. So this stuff matters on a whole series of levels. I've talked a lot there, obviously, about numbers. But the other thing, obviously, which is really important is we don't just want any old healthcare system. We would like a healthcare system that actually meets our needs, I think. And one of the things, obviously, in numerous iterations of national policy over at least the last 20 years that we've been talking about, is with the ageing of the population, the rise of chronic disease, and now increasingly multimorbidity, that we need to rebalance services away from an acute and episodic focus towards more services in the community, more focus on prevention, early detection and support. And it's very hard to find anybody who kind of disagrees with that. What is quite interesting then is when you look at what we've done in terms of who we've employed and where we've employed them, is between 1996 and 2016, this is hospital doctors, GPs, nurses and other staff per head of population. We've had a 70% increase in hospital doctors per head of population and a decline in the number of GPs. We've also had a really interesting skill mix change where we've increased doctors a lot more than nurses, which may be a good idea. I couldn't find anything written down in the policies that explained that, and then how and what it meant for quality of care and delivery of care, and how we were going to implement it. It is quite interesting. I could make arguments for it, I think, but they would be post hoc rationalisations of what had happened there. And certainly, if you had read sort of broadly every major policy report over the last 30 years and thought, what will that look like in terms of workforce trends? I would argue that it would be quite hard to come up with that chart in anticipation. So we really do have a question not just of numbers, but then also of where we're putting that. And the GP specialist thing is not that surprising, but again, sorry, I do reduce things a bit. Actually, you look at the pay, and it's not that surprising. So in a service that prides itself, throughout the NHS as a primary care-led service that has, across the globe, put some of the main emphasis on family doctor services, amongst the countries for which I could get data, our specialists relative to GP's pay is amongst the highest across the OECD countries that there is data. So who would be a GP, really? And if you want people to be GPs, is this a logical pay structure? Probably not. So in all of this, I think the key thing, which Candace Emerson says time and time again that you see, is it's really hard to see very clearly the relationship between the workforce and the work. And it's very hard to see that the work, what we need to do to deliver healthcare effectively and efficiently with changing needs, changing technologies, is really driving the decisions about the workforce policy. And so She has some lovely examples of that, which I just thought I'd share, which is, so she's done some work with a number of people in the Main who are or used to be at the Nuffield Trust, at individual hospitals, where case mix is relatively consistent, but the variation in senior consultant staffing is hugely variable, yeah? In ways that they cannot explain with any available data. So I've no doubt left you full of cheer about the NHS. It sort of gets a bit worse now because I'm going to talk about social care. And this really does make me feel quite scandalised that we sit as a society and have allowed some of these trends to occur. And I'm going to share here some wonderful data from Skills for Care, who I think are doing a really important job in shining a light on a sector that is not well understood by people, and yet so fundamentally important to people's ability to live independently and with dignity. And in workforce terms is as big, if not slightly bigger, than the NHS. So turnover rates in selected jobs. So overall turnover, 30% in a year. It's a huge cost of turnover, obviously, but if you're thinking about someone at home needing care, it's a really intimate relationship. You're letting someone into your life in the most often personal and profound way. And what this means is that, you know, they're changing all the time. Particularly when you see that it is care worker that is on a turnover rate of 40%, yeah, which can't be good. And again, what we see is that although the rises in the living wage have helped many in social care, they've also actually applied to a lot of other jobs as well. And actually, social care work is becoming less attractive than many other occupations. So kitchen and catering assistants, yeah, again, actually differential. In fact, sales and retail assistants now employs more, which is why, you know, the opening of Lidl or Aldi is one of the biggest risks that most care homes or domiciliary care providers would have for their ability to continue to maintain services. Second thing, 0 hours contracts. So the proportion of staff in social care who are on 0 hours contracts, yeah? Care workers in daycare settings, 58% are on a 0 hours contract. That should say registered nurses, yeah? Half of domiciliary care registered nurses, again, are on a 0 hours contract. So if we want to do integrated care, yeah, where we deliver multidisciplinary teams wrap round a patient, yeah, with ever more complex needs to support them at home, I don't understand how you do that with turnover rates of at least 30%, 40% for the care workers, where people are on a 0 hours contract and Lidl is paying more. And think that that is ever a sustainable model for doing that. Added to which, then, we are not investing in training those staff as the job gets ever more complex, and quality must be linked to training. So not surprisingly, with these sorts of turnover rates, half of staff have no relevant social care qualifications. The number of apprenticeship starts in social care last year halved. Yeah? So we are not investing in staff to make this even a satisfying job, let alone providing a career opportunity. And with the minimum wage, The premium to experience, if people are prepared to stay, has fallen even more. So, in March 2019, if you've been working as a social care care worker for 5 years or more, compared to someone with less than 1 year, you're earning 15p an hour more. Yeah, so that differential used to be 4 to 5% back in 12-13, which wasn't great then, I don't think, but it's now down at 2%, 15p more for 5 years experience. Leaving aside the practicalities of actually living in this context, what does that say about how far we're valuing people and the experiential skills that they've developed and the contribution that they have made? And do you remember back to my earlier slide? We need 40% more over the next 15 years, social care staff. Again, we've managed a lot of this by international recruitment, very geographically dispersed. If you take London, only 62% of staff are British, and a quarter of social care staff are from the non-EU. It's not clear at all at the moment in the post-Brexit migration policy how we will be able to recruit internationally. So we have to, I mean, and actually, kind of morally, we need to sort out what on earth we're doing with pay and terms and conditions for social care staff, both as a social justice issue for those staff, but also for a quality concern for the service, and if we're to be able to deliver any sort of real integrated care. And actually, I would argue integrating budgets is fine, but against this workforce picture, I don't see how integration ever becomes real unless we start to really transform what we're doing on the social care workforce. And in fact, what we're seeing at the moment with the agenda for change is that NHS jobs are becoming relatively more attractive, and certainly many in the social care sector who are running nursing homes are saying that well, a lot of them are converting them to residential care homes or giving up because they just can't get the nurses anymore. One hope might be automation. This ONS study looking at the probability of jobs being automated, other people could give you talks that explain how it's all fine because none of us are going to need to work in the future because the computer's going to do it all, or the robot. So there's been a big study done looking at the probability of automation by different sectors. Overall, they find, this is a wonderfully precise number, isn't it? I was going to round it and then I thought, nah. 53.83, definitely the 83% of all jobs are at risk from automation. It's the ONS, so it must be true. See, medical practitioners and nurses, like most professional occupations, way down the bottom there. They do think that some of care work could be automated. So, maybe that will help us a bit. But certainly on the core NHS workforce, it's difficult to see that automation is going to provide the answer. The other thing to say is that automation overall in the economy should drive productivity. Yeah? And many of you will know that one of the things that in healthcare people think about is Balmole's cost disease. Why is healthcare more expensive and computers get cheaper? And Balmole, when he started out with this, started out with the orchestra, I think it was, example. So, I mean, my daughter plays clarinet. So, and she did the Mozart clarinet concerto. So when Mozart wrote that clarinet concerto, you needed the same number of people to play the thing as you need today. Yeah? You were probably not paying them very much then. So if wages rise by productivity, yeah, by and large, clarinet player, pleased to say, she's not going to do the clarinet as a job. Clarinet player shouldn't have had a pay rise in 200 years. But of course, the rest of the economy, productivity has grown. And so we do actually pay clarinet players more now, because if we don't pay them an amount that is vaguely competitive with other things that they could go and do, they won't do it. So actually, what drives their wages is not their productivity as a clarinet player, it is what's happening in the economy as a whole. So oddly, although automation might help some things in that, we in social care might need slightly fewer care workers, actually if it drives productivity up and drives average wages up across the economy, it's what you'd expect. And in healthcare, for nurses and medical practitioners, we can't automate, we're a bit more like clarinet players. Actually what you see is the wages for doctors and nurses needing to rise to keep pace with all the tech wizards who are working 2 hours a week and earning a fortune. Yeah. So despite this, which I think is the critical issue, I did 2 word clouds. It's good fun. Recommend it. Of the 5-year forward view, and that is the word doctors. I tried to look at any word that related to the workforce. And then I did the NHS long-term plan. There was the word staff somewhere in there, yeah? And notwithstanding that it's not exactly central, we do now have a commitment to a people plan, and we had an interim people plan. So what do we... So I'm going to finish up with just some thoughts, which hopefully then will lead into the discussion, then, is given that backdrop, and I hope that you think, even if you disagree with some of my dodgier numbers, that it's reasonable to assume that we might have a problem that we need to take seriously. What should a workforce strategy now, if we are going to get serious about it, look at? And I think there are 3 really big issues that we need to grapple with in this. So the first is the one of scope. Yeah? Is this just for the NHS, which is what the commitment is for the people plan? I think that is at the heart of one of our problems in previous exercises in this regard, because it ignores the fact that actually quite a lot of publicly funded healthcare is delivered by organisations other than NHS hospitals, yeah, and they need staff as well. It ignores completely social care, obviously, and so I think at the very minimum, we need to think about all of health and care together. The second thing is, what's our approach? So we tended to have a capacity planning framework for numbers, and broadly just that, largely as well only for the professions where we publicly fund the training. So it's most developed for doctors, that it's somewhat developed for nurses, and there is nothing really beyond that. I would argue, building on work that the WHO have done, that we need really explicitly to adopt a labour market framework, and I'll come back to that. The second thing I think in the approach that we need to think about is, are we having a plan or a strategy? Yeah. So almost everybody, when you argue for work in this area, will say, but you can't know. Yeah, you'll write it down, it'll be out of date, it'll be spurious precision, yeah? There's inherent uncertainty here. All of that is true, but either by the decisions we currently make or our choice not to think about it explicitly and make decisions, those actions have consequences because of the time it takes to train and the extent to which we in the decisions we make about pay, terms and conditions, the way we organise careers, etc., we are creating an incentive framework. And I think we need to think a lot more about a strategy, and we need to think a lot more about our approach to that in terms of frameworks for making decisions under uncertainty. So no one can say what technology will do over the next 15 years. And actually, it is genuinely, to go all Rumsfeld, it is genuinely unknowable, isn't it? But there are tools that many business schools and others have developed, to think about how do you try and make good decisions under uncertainty. And actually a lot of what's happened with climate change is beginning to think and providing frameworks for making decisions under uncertainty, and really starting to think, well, what decisions are reversible, over what times, what's our risk appetite, what's the degree of consequence, are those consequences themselves reversible or irreversible. And I think alongside whatever work we do here, and for academic work, I think it's really important to start to think and break this, because there's uncertainty, I shouldn't do anything now, and I shouldn't think about the future, and or actually it's just a question of me modelling and producing an ever more accurate number and ignoring the uncertainty, actually bringing a lot more of the science and research about good decision making under uncertainty to the question of the workforce. And then the other big question is national versus local. And I think the more you start to think about this from a labour market framework, and you think about the totality of the workforce, you see, and I'm going to use what was, showing my age, a word that was quite fashionable around European policy for a while, subsidiarity. In some cases, this needs national decision, but actually, if you don't understand the diversity of local labour markets and make appropriate decisions for that context, one size will not fit all. So how we get the right level of subsidiarity and the right then skills within the system to operate on those issues at different levels, I think is really key. And so then just to briefly mention then, what is the labour market framework? And the WHO kind of developed this. And I think it's really, we have quite a lot of focus on the education sector, but actually only a subset of the education sector, really. You see FE policy very rarely discussed in relation to health and care. And yet, when you look at the proportion of the workforce, FE should be central. They're almost never at the table. Either we've struggled enormously with apprenticeships, as I was suggesting. And then when we do focus on the education sector, then the wider dynamics, labour market dynamics, we don't think about. And so if we were thinking about that, we would have, this is WHO speak, policies on production is a horrible phrase, isn't it, for people. So obviously we do need a series of policies about how we educate and train, and how we select people in as well to that education and training. We have a whole lot of policies about the inflow and outflow, for which need a lot more behavioural science, I think, to understand those dynamics, to inform policy. We need to think a lot more, as I've alluded to maldistribution, to the fact that we've been growing our specialists at a time when all of our policy has talked around generalists. And then this is a highly regulated sector for good and ill, and we need to think a lot more in a joined-up way about regulation policy. Regulation is very diffuse and separate from a lot of the other areas. And just to emphasise some of that, it is really interesting that both doctors and nurses report simultaneously being underskilled and overskilled. In work there. So we do have lots of issues of skills mismatch as well. And if we're to, and the result of that is quality and safety, inefficiency, and also jobs dissatisfaction and turnover. And the solution to that is not one single policy. It's about joined up policy making across a range of levers that operate with different bodies and at different levels in the system. And this is one of the reasons why I think we don't do it, because it's hugely complicated, because it's about everything in the end in many ways. And so how do you put some boundaries around this? So the workforce issues, a lot of these issues arise because of funding issues. And a lot of what you need on the workforce then links in, obviously, to what the service model is that you want. So everything's connected to everything, and that's just within the healthcare field. And then you start to think, but then that service model is connected to technological and medical advance, and that's a whole other set of issues. The workforce issues are linked into the education system, to public policy, as we've seen very recently, you know, Treasury policy on pensions, yeah, that has just mucked up a huge amount of capacity in the NHS. It wasn't an NHS-specific policy. So how you make policy in a way which becomes tractable and someone can get their grip around and be accountable for, but do that in a way which is cognizant of the fact that everything is connected to everything else, I think is one of the reasons why this then ends up in the too hard basket. Yeah. I think also within that, because of the very politicised and short-term nature of healthcare, and this is my last slide, when we do this, and you see this at the moment with the people plan, it ends up, again, being very short-term and tactical, and not really thinking about the bigger issues that really have shaped how we got to where we are. And so I just thought of 6 things. I'm not necessarily advocating all of these, which really ought to be the things that we're debating and thinking about, but you actually don't really see, because at the moment it is all very short-term and tactical. So if one of the stories of the healthcare workforce since the founding of the NHS has been of shortage, yeah? And yet that has had such significant consequences. And we try repeatedly to land the, airplane on the postage stamp of exactly predicting the right number of nurses that we will lead in 10 years' time and training that number and only that number, because heaven forfend we might train someone that isn't needed, which is in itself, as an economist, a strange concept, which implies no transferable skills whatsoever. What about moving to a policy of oversupply? Yeah, or at least debating it, yeah, and thinking through that. And we could think about that as well as from a whole government point of view. So, one of the government's other policies at the moment is to think about the industrial strategy, try and deal with that productivity problem that we've got in the economy as a whole, which is why living standards haven't increased. And a big part of the industrial strategy, especially trying to move away from an over-reliance on financial services, is to think about life sciences. Now, what is one of the biggest barriers to life sciences locating and growing in the UK? Lack of workforce. A lot of the skilled workers they need have skills in healthcare. So if we trained more and it turned out by chance that the NHS didn't need everybody, yeah, there are quite likely to be other things that they could do which would be good for them and benefit the economy as a whole. You really see then with this uncertainty, we put huge proportion, about 98, I think, % of the investment in education and training in our workforce into initial training. And that makes really very little sense, either from a flexible workforce, from a productivity point of view, and from an adapting to need. When we look at the social care situation and a lot of the anchor stuff, it's the movement between different staff groups is I think nowhere near as much. Very few nurses become doctors. That's quite interesting. Why? Go on to train. Career escalators in our system are very limited. We've got geographical issues. A lot more focus on. There's some evidence that on training locally and recruiting locally and then training. It is a really good retention strategy. Doing a lot of work in response to morbidity in multidisciplinary teams, and yet which seems to be ever more people coming together around a patient, rather than us sitting back and thinking, hang on, people have got this complex mix of stuff, maybe we should be training people so that actually one person could meet more of that individual's health need, rather than it taking 5 or 10, or what's the Smith example? 50-something, isn't it? involved in the care of Mrs. Smith, and really, really redefining roles and professions. I have a real question in my mind, which I think merits really serious thought and debate. Can we actually do anything serious about social care while it remains an unregulated and unregistered profession? If we were actually going to really try and sort out social care, would we need the structures of regulation and registration, particularly as I start to think about migration routes, about pay and things like that. And the other thing, which I think is quite an interesting one, is the extent to which, there's quite a live debate, I think, in mental health. Do we need, in some cases, always more healthcare workers? As we start to, is that too much of a biomedical model? And essentially, are my demand numbers wrong? Could we meet more of that demand, actually, by shifting our focus, and we're seeing this now with social prescribing, I guess, to a wider role for non-medical staff, and thinking through what that would look like, particularly as we start to understand the importance of social determinants of health. I'm not advocating any particular one of those, although I think I probably am on oversupply. I think I've broadly convinced myself of those. But I think these are some of the things, and others will have the list, that if we were serious about this, we'd be talking about, rather than what I fear is going to dominate in the people plan at the moment, which is the very traditional, tactical, NHS-specific status quo solutions, which I just don't think are up to the scale of the task. Okay.
So we've got some time now, probably about 10 minutes for some questions for Anita. So if I can invite questions from the audience. And